welcome. Happy Valentine's Day from all of us from the Worcester Senior Center. Thank you so much for coming today. We have a really wonderful program. Just one housekeeping note, please turn down or put on vibrate your phones. The doctor spent a lot of time on this presentation and it's his time, so thank you, doctor. In honor of Heart Month and as part of our Distinguished Speaker Series, the Worcester Senior Center welcomes Dr. Mark O'Connor, cardiologist at St. Vincent's Hospital. Welcome.
Thank you. Good morning, everybody. Happy Valentine's Day. It's an honor to be here and to have a chance to chat with you today about a very appropriate topic for February 14th. So I would like to take this opportunity to talk about a few things. I'd like to talk about some common forms of heart disease, some of the most common cardiovascular conditions that we treat every day in heart clinics here in the Worcester and Central Mass community and frankly around the world. Heart disease is thought to be the most common cause of death across the world, so it's something we're always busy with and take very seriously. So I'd like to tell you about some of the common forms of heart disease that we deal with, and then also talk about ways to lead a healthy and happy lifestyle to avoid heart disease as much as possible. And we're going to make plenty of time for questions, so I want to make sure if you have any questions coming into this talk, or if you think of anything you'd like to know about as we're chatting today, I'm very happy and willing to answer any of your questions. So there will be plenty of time for that as we go. So the first part of our talk today is just to go over a few of the common cardiovascular conditions that we treat. These are just three of the most common things we deal with. We could spend a couple hours talking about any one of these conditions, but I'd like to hit some of the most common points about these. Coronary artery disease is the big one. There's also atrial fibrillation, which is a type of abnormal heart rhythm we see often, and then congestive heart failure. So I'm sure many of you are already familiar with these conditions to some degree, and we'll go into them in detail. So the first is the big one, coronary artery disease. So this is usually what people are talking about when they say heart disease or hardening of the arteries or plaque in the arteries. This is one of the most common forms of disease in the country and around the world. And there are many conditions that can put us at increased risk for coronary artery disease. And simply just as we get older year by year, our chance of developing coronary artery disease goes up. So the first thing I want to do is just describe a little bit about what it is. So on the left, there's a kind of a simple picture of a heart outlined in white. And the red diagonal squiggles, those are the coronary arteries. And the coronary arteries are these small blood vessels that supply blood to our heart muscle. So, of course, the heart's pumping all day and sending blood to all our organs in different parts of the body, providing oxygen and nutrients so that we can function. But the heart itself, which is a hard-working muscle day in and day out, it needs its own blood supply too. So the way the heart muscle gets energy and oxygen so it can beat all day is by the coronary arteries. And you can see they're really not that big. They're thinner than a regular drinking straw. So these coronary arteries that are critical to our heart muscle function are pretty small. So we have to take care of them the best we can to keep a healthy heart. So there are three major coronary arteries. There's one large one on the front of our heart, and then there's one on the right side and one on the left side. And they have little branches, each of them, that supply blood to the muscle. So what a heart attack is development of plaque or a blockage in one of these coronary arteries. These little arteries, if they get blocked up, we can't get muscle to our, we can't get blood to our heart muscle. The heart can't beat. You can get chest pain, and you're going to feel sick pretty quickly. And then on the right side, you just see a picture of a normal, kind of a side view of a normal artery on the top right, without any plaque. And then, of course, down on the bottom right is a picture of an artery that has a large plaque. So that's kind of, on the bottom right, that's kind of what it looks like when someone is developing a so-called blockage in their heart or in their artery and having a heart attack. That's kind of what it looks like. You can see there's not much blood that's going to be getting through that artery to the heart muscle. So this is a very common condition, and there are a few things we'll talk about in more detail in just a few minutes that can lead to plaque buildup. One of the big ones that we all know about is smoking. Now, most of us are not smoking these days, and certainly not smoking the way people used to. Times have changed, fortunately. We know a lot more than we did decades ago. But it's still important to mention that tobacco is one of the leading risk factors for developing plaque like that. The reason is when you smoke, your body develops a lot of inflammation, and that inflammation can lead to plaque buildup. Just a few notes on other things that can lead to plaque buildup. Another big risk factor is diabetes. Diabetes can cause early development of plaque buildup in many different people. And then there's a couple other common risk factors: high blood pressure and high cholesterol. Another risk factor can be genetics. Some of us inherit an increased risk of developing plaque and blockages in our arteries. So first off, there are these few things that can lead to plaque buildup, and most of these things we can control and try to treat before we develop significant plaque buildup. We'll talk a little bit more about that in just a while. And now, it used to be cardiologists, sometimes I talk with my patients about how we heart doctors used to be like firefighters. We would come in and try to help people and try to save the day after they've developed a blockage or a heart attack. There are different ways we can treat blockages and treat people when they're having heart attacks. There are many types of medications. There are procedures. Some of you may have heard about stents, or know someone who's had a stent put in to open up a blockage like that. And some of you may know people who've had surgery, bypass surgery, to create new blood vessels to go around these blockages. So for years, that's what we've been doing in cardiology, treating these emergencies whenever they pop up. And unfortunately, they are very common in hospitals all over. We're dealing with this every single day, sometimes by the dozen. But these days, we're also very interested, and just as interested, in helping prevent this from building up in the start. So we work very closely with primary care doctors and diabetes specialists, nutritionists, and the patients to try to prevent this from happening in the first place. There are a whole host of medications we have to try to prevent and try to treat coronary artery disease. I would say the two most common types of medicines we use are medicines to lower cholesterol. Statins are probably the most common type, but there are a few other types as well. For people who have had heart disease or had a heart attack, we of course have aspirin, and we have some other types of blood thinning medications as well. And in a few minutes, we'll talk a little bit more about ways we can try to prevent more plaque buildup. Now, atrial fibrillation is one of the most common conditions we treat as well. This is a very common abnormal heart rhythm. Millions and millions of people across the country have atrial fibrillation. It's sometimes described as an irregular heartbeat or an erratic heartbeat. You may have seen commercials about it on television. many people develop it as they get older, or if they have other risk factors for heart disease, just like the ones we've already talked about. Atrial fibrillation can be a tricky thing to treat, partly because about at least 50% of people who have it don't feel anything. So you could be walking around for a while with an irregular heart rhythm and not even know it. Other people can certainly get symptoms. You can get shortness of breath, you can get fatigue, you can get lightheaded, you can get chest discomfort, you can lose your strength and stamina. It can cause all kinds of problems. And this is just another drawing of the heart, just a kind of a cross-sectional picture of the heart, where we have those two round things up top, are the top chambers of the heart, and the kind of triangular-shaped cavities on the bottom, or the bottom parts of the heart. Those are called the ventricles at the bottom, and the top chambers are called the atria. So atrial fibrillation is an irregular type of heart rhythm, and it comes from the left upper chamber of the heart. On the upper right is an example of an EKG, or a picture of a heart rhythm with atrial fibrillation. And you can see those blue spikes are not evenly spaced apart. So when you have atrial fibrillation, instead of your heart beating steadily, kind of like a Swiss watch, it speeds up and it slows down over and over. And that can put some extra stress on the heart and make it hard to function and do your daily activities. So for atrial fibrillation, there are a couple things we do. First, we treat symptoms. So we make sure the heart is not beating any faster than it needs to. We have various types of medications we can use to do that. And sometimes, actually oftentimes, we work to reset the heart rhythm. There are ways we can get the heart rhythm back to normal. Sometimes we use medications, and sometimes we use procedures and even surgeries. Some of you may be familiar with this condition already and know someone who's had a cardioversion or an ablation. So there are a couple different ways we can reset the heart rhythm. The biggest problem about this very common heart rhythm is it increases the risk of stroke. So that is a big problem that we face and treat every day for people with atrial fibrillation. The reason it increases the risk of stroke is because when it causes the heart to beat irregularly, it makes it easier for blood clots to form in the heart. And if you get a blood clot in the heart, of course, that's a very bad thing, and that blood clot can move to other parts of the body, like the brain. So many people with atrial fibrillation take blood thinners. And I'm sure some of us have seen commercials for these blood thinners. Some of the common ones you might have heard of are Eliquis, Xarelto, and then there's also warfarin or Coumadin, which has been around a lot longer. So these blood thinners make it so that we're less likely to have blood clots in our heart when we have atrial fibrillation and significantly lower the risk of stroke. So we can take a moment and see if there are any questions now. Okay. Thanks.
So do you ever treat with K2 for our, the plaquing? And do you use K1 for blood thinning? They're minerals.
Are you talking about vitamin K?
Yeah, vitamin K.
We don't use vitamins. That's a good question, and we can certainly.
It causes plaque.
Yeah. So we don't treat with vitamins for this condition. Atrial fibrillation, this particular heart rhythm condition, is so very common. We've been able to do many research studies across the country and across the world on it.
Right.
And from all this research, we've found that certain blood thinners in particular are the most effective to prevent clots. So like the ones I mentioned, I would say the most common three are Eliquis, Xarelto, and warfarin, have all been shown to significantly prevent clots and limit the risk of stroke. Other things haven't been shown to work as well in terms of lowering the stroke risk. And one other thing I would point out is that aspirin actually doesn't have a big effect. It's not very helpful for this condition. We use aspirin all the time for people who have had heart attacks and strokes to prevent other types of blockages. But for this condition, we don't use aspirin.
But what about vitamin K2 for the plaquing in arterial?
We typically don't use vitamin K for that. But warfarin has an effect on vitamin K in the body. So warfarin is related to that. That's how it works.
Hi, could you talk about the difference between atrial flutter and atrial fibrillation?
Absolutely. So, as I mentioned a few minutes ago, there are so many different heart conditions that we treat, and I just listed a few of the most common ones today, but that's a great point and a great thing to bring up. There's another type of irregular heartbeat that is similar to atrial fibrillation, and I'm sure some of you have heard about it. It's called atrial flutter. Now, it is another erratic, irregular heartbeat. It comes from a different part of the heart. It comes from the right upper chamber, and it has many similarities to atrial fibrillation. It can cause a lot of the same types of symptoms: trouble breathing, chest discomfort, dizziness, and it is also, most importantly, it's also related to an increased risk of blood clots and strokes. So we actually treat it in a very similar way. We use the same types of medicines to relax the heart and protect the heart. And people with atrial flutter are also candidates to take blood thinners, like people who have atrial fibrillation. And lastly, people with atrial flutter are often also candidates to get procedures to try to reset the heart rhythm to normal. So they're very similar, and we treat them in almost the exact same way. It's just that that atrial flutter rhythm comes from a different part of the heart. Thank you. So that's a great question, and sometimes it's tough to know. So this comes up in the heart clinic all the time. Patients of ours will call us and say, "Doctor, I'm not feeling right. I don't know what to do. I don't know if I should come and see you in the clinic. I don't know if I should stay home and wait it out. I don't know if I should go to the hospital." It depends on a lot of different things. Many times, we can treat these conditions in the clinic. If we recognize them early, we can treat them early and prevent trips to the hospital. But sometimes, my general piece of advice for your very good question is, go with your gut feeling. If you just don't feel right, if you feel like you need help quickly, you can call 911 or go to the ER anytime. We're always open, and that's what we're there for. On the other hand, our heart clinic and other clinics all over the place, we're ready to answer calls too. If you're not sure, we can talk with you about that. So the bottom line is, it really depends. It depends. In some cases, people do need to go to the emergency room. In other cases, we can treat them in the clinic. Well, for these conditions we're talking about right now, the heart rhythm conditions, an aspirin really won't do much for this. If you're having chest pain, you feel like you might be having a heart attack, that's a time when we do give an aspirin. Yeah. You can, yeah.
What is a cardio or heart ablation?
Ablation is a surgery, and it's a type of surgery that can get rid of these abnormal rhythms. One of the good things about this type of surgery is that it's not an open heart surgery. So it's not a kind of surgery where people need to be cut in their chest. With an ablation, the doctors can access and get into the heart with their instruments by going through veins and arteries in the leg, pardon me, in the groin. And what they do is they go into the heart with their instruments and they can apply bits of heat or freeze the small areas in the heart where these rhythms come from to get rid of them.
Is there a recovery period?
Yes. So if you were to have an ablation surgery, most people, fortunately for that kind of surgery, can go home the same day. And you might just kind of take it easy and rest up for a week or so.
Thank you.
You're welcome.
On that topic, how successful are ablations and how risky?
That's a great question. So for some people, when they have these rhythm problems, we can treat them with medications, and luckily we don't always have to do procedures or surgeries. But there are a fair number of people who still have symptoms and we can't get the rhythm to calm down or go away just with medicine alone. So we use either a cardioversion procedure or an ablation surgery sometimes. Most of the time, the ablation procedure works. And the effect and the treatment can last for years. It's not guaranteed to last for life, but most people can, after an ablation, can go years without having trouble with the heart rhythm issues.
Do most people that have these sudden heart attacks, have they had prior warnings they may have disregarded?
Well, that's a great question, and it's a mixture of both. So, going back to the topic of coronary artery disease, some people may have symptoms for a while, and this can be tricky for the patient and for the doctors or the healthcare providers. Some people might have a feeling of heartburn or just start having trouble breathing, little bits of chest pain that are kind of mild, and it can be for a few days or even a few weeks before it starts to build up and get worse. And it can be tricky sometimes to know what's going on, because in our chests we not only have our heart, but we have our throat and our stomach. Many of us have issues with heartburn or acid reflux. We have muscles and bones that can ache. You can get arthritis in the chest, just like you do in the knees or the hips. You can get pain in different tissues around the lungs. So there are many different things that can cause chest pain, and it can be confusing sometimes or uncertain as to what causes that. So yeah, some people can have symptoms for days or weeks, and we in cardiology, we end up seeing a lot of those people in the clinic, and we run tests to try to figure out what's going on. One of the common tests we do in a case like that, if someone's been having symptoms for a while, is something called a stress test. We can have someone exercise on a treadmill or do scans of their heart to try to see if there's plaque buildup. So yeah, many people do have symptoms leading up to a heart attack or a heart event, but unfortunately some don't. And that's why prevention is so valuable and so important. Some people don't have warning signs, and that's when our emergency treatments become so important. Things we have, at our hospital down the street. Things sometimes we have no choice. We need to use things like stents or surgery, bypass surgery, to treat people in emergencies. So it is a mixture of both.
I have, it's a two-part question. Number one is, I've noticed that they don't do as many bypasses anymore, that they put in the stents, but they both last about the same amount of years, 6 to 10 years. My second question is, while we have Coumadin and all these wonderful medicines, when you listen to the commercials on TV, by the time you're done listening to the side effects, you're freaked out. Because one of the side effects is internal bleeding, and there have been cases, I just heard of one the other day, that the woman was put in on the second medication you mentioned, and she was internally bleeding, and they didn't notice it until it was too late. So I'm going to leave that in your hands.
Yeah, those are important points and good questions. So the first thing is, when we're dealing with someone who has a blockage, we're in an emergency situation, and they're rushed to the hospital, we have a few different options. And it's usually a decision between putting in a stent or maybe a bypass surgery. And a stent can be put in without surgery. Again, it's not involving open heart surgery. We put stents in through by getting into an artery in the wrist. We use instruments to get into the heart that way. So there's just a pinpoint little spot that we can access your artery to get in and fix something like this when you put a stent in. Bypass surgery is much different. We have to make a large incision, a large cut in the chest. Our surgeons do, and that involves a very long recovery. It works very well. It treats the problem, but recovery is longer than when you have a stent put in. So the decision on which intervention to use, whether it's a stent or bypass, it kind of depends on how many blockages there are and where the blockages are. And it might also depend on other parts of the patient's health. If they have diabetes, in some cases, if someone has diabetes, bypass can have a better long-lasting effect in some patients with diabetes. Or if someone already has a weakened heart muscle, sometimes bypass can have a better long-lasting effect. But as you mentioned, stents can last a long time. And they can often last decades. They don't always, but they can, and so can bypass vessels. So we probably do stents more often than we do bypass surgery these days. There's no question. There's quicker recovery, and if there's only one blockage, that's often how we do it. But we still use both, and it just depends on the individual person's situation and their health background in terms of which one we choose. And then your second great question is back to the blood thinners that we sometimes use or often use for these heart rhythm conditions. So we have to take great care when we prescribe blood thinners because they can have side effects. They're strong medicines, they thin the blood, but they do increase the risk of bleeding for anyone who takes them. Most people who take a blood thinner don't thankfully have serious bleeding issues. They might not notice anything at all, but some people find that they bruise more easily or a paper cut takes longer to heal. But there are some people who develop bleeding issues. So if we use blood thinners, we have to be very, very careful, and we have to check in with our patients often and run routine blood tests, because we always have to have in the back of our mind the fact that a small percentage of people could develop issues, and we have to be ready to deal with that.
Someone mentioned vitamins earlier. I'm curious if you get a new patient, do you do ever like comprehensive blood tests or nutrition panels, and do you do like intracellular versus extracellular tests, and do you see differences between the two tests? If that's something you guys consider, yeah. Yeah,
so I would say if I'm seeing a new patient, most of the time, if let's say I'm meeting a new patient who hasn't had a heart attack or fortunately hasn't had any major heart problems, but wants to make sure they're doing everything they can to prevent heart disease, there are a few main things I talk about, and we'll cover that a little more in a few minutes. It's what's your lifestyle like? What's your diet like? How active are you? What's your family history? Do you smoke? Do you have diabetes? Do you have blood pressure? Do you have high blood pressure? Do you have high cholesterol? And if you have any of those things, how's it going? So that's where I start with the basics. I always keep a close eye on the blood pressure. Those are the first numbers I look at. I want to see someone's cholesterol levels, and there are different ways to treat that. It doesn't always have to involve medication, but I want to see where the cholesterol levels are, and blood sugar. I want to see if someone is in the diabetes range or pre-diabetic. So those are kind of the main things. Now, in terms of vitamins, intracellular electrolytes. There are many, many, many different types of blood tests you can do these days. Generally speaking, when it comes to vitamins, probably the most common vitamin deficiency we all have around here is low vitamin D. So that's a very common thing that, just speaking about general health, not just heart health, is something that warrants treatment. For most of us, if we don't have a vitamin deficiency, a disease causing low vitamin levels, I don't necessarily check that on everybody. But it depends. It depends on the individual patient, how they're doing and what they're interested in, So that is something that comes up sometimes. Yeah.
Is the on the previous picture, is the plaque buildup reversible, or once you have it, is it constant, or
Yes.
do you just do that? And my other comment is, if you are taking any of those medications, I think you just need to apply to be an actor, because none of those people on commercials ever have side effects. They're leading wonderful lives.
Yeah. So that's a wonderful question. So we have not yet found a way to dissolve or melt away plaque. I hope someday we will, but we have not figured out a way to melt away or dissolve these plaques. When we treat someone who has a heart attack or a blockage, we can open up the blockage with equipment. What a stent does, a stent is a little metal device. It's a little metal tube that can push plaque open. So it can push plaque to the side and create an opening again in the artery. Or a bypass surgery puts another artery in the heart to go around the blockage. But we have not figured out a way to dissolve and melt away and reverse that yet. There's always research going on to try to figure out ways to do that. But what we are very good at now is preventing this from building up in the first place. So some of the ways to do that are very simple with diet and exercise, and some of that can involve medication depending on your risk factors. So that is something we work on all the time, trying to prevent this from forming in the first place.
She has a question. She's going to tell me in Spanish, and I'm going to translate for you. She said that at 19 years old, she got something called thrombophlebitis, which is a cognate, right? So it's probably the same thing in medicine. And that 4 years ago, she got a thrombosis. And she's on Eliquis? And she's presently on Eliquis. So her question is, which is better, Eliquis or an aspirin? And how long does it take to go into effect? How long does the Eliquis takes to go into effect?
So Eliquis and aspirin have some similarities, but they can be used for different things. So if you have, thrombophlebitis that usually involves a blood clot in one of your veins, and those can sometimes be very, very serious and life-threatening. One term used for blood clots in the veins is, and you might see this on TV, is DVT-PE. That stands for deep vein thrombosis, pulmonary embolism. So there are types of blockages and clots that can form in the veins. That's different than what we're talking about here, but it's very serious too. So that, if you had a blockage in your vein, you would most likely be on a medicine like Eliquis and not aspirin. And then if you're taking a medicine like Eliquis, it starts working to full effect within about 2 days. It starts to thin the blood just within a few hours of taking the first pill, but it reaches its full effect within about 2 days.
Since a blood clot can kill you, once you get rid of the plaque, where does it go? How come that doesn't go to your brain or your heart and kill you?
Well, if we're talking about a heart attack, I'm just going to reach up and use an example. So that's a coronary artery right there. And if you get a blockage, let's say you get one right there, the plaque is only going to, it doesn't have really anywhere to go. So this area won't connect, fortunately, to other parts of the body. So in a situation with a heart attack, it really can't move to other organs. But on the other hand, as we were talking about earlier, so the problem with a condition like atrial fibrillation is those are clots in different areas, and they can move because they're not in the arteries. They're just in the chambers of the heart, and those are the blood clots that can go to other parts of the body, like the brain. I'll take one more question and then move on to a few other topics. We'll have plenty of time for more questions in a bit. The big ones are to make sure we're going to ask about smoking. We're going to check the blood pressure, of course. We're going to be looking at cholesterol, and we're going to be looking at your blood sugar. Those are the big ones that we are always looking at, both in the cardiology clinic and in primary care. Good question. We don't do stress tests for everybody. We will do stress tests whenever someone has symptoms that are concerning, like if someone's having chest pain when they're climbing upstairs or doing their usual activities, or someone's getting short of breath more often than usual. We'll often do a stress test to look into that and see if there are signs of plaque buildup. But if you're feeling well, we won't necessarily do that. So, okay. So one more major area of heart disease is congestive heart failure. A very common condition can come from many different causes. There are many different types, and it's very hard to treat. Congestive heart failure is a condition where the heart is not pumping with normal strength. Either the muscle could be weakened, or the pressure in the heart is too high, so it's not pumping with normal efficiency. And again, there are many different, this is a very broad type of illness, many different types. It can present in many different ways, cause different symptoms. We could talk about this for hours, but I just want to tell you about some of the main points. It's extremely common. Millions and millions of people can develop it. The most common cause is coronary artery disease. Plaque in the arteries is the most common cause of congestive heart failure. But some of the other most common causes are having high blood pressure for a long time that hasn't been treated for years and years. Diabetes can directly contribute to heart failure. There are even certain types of infection, heart valve disease, autoimmune diseases, inflammatory diseases, many different things. Genetic conditions can cause congestive heart failure. So when the heart is a pump, and when it's not pumping with normal strength or normal efficiency, people can start to feel pretty unwell pretty quickly. Probably the most common symptom is shortness of breath and fatigue. You just can't do the things you'd normally be able to do. You can't climb a flight of stairs. You can't even walk for a few minutes on flat ground. You can get cough. You can have trouble breathing when you lie down. You can get swelling in the abdomen, in the belly, or in the legs, and you can get fluid in the lungs. One thing I would mention is just because you have swelling in the legs does not mean you have heart failure. So that's an important thing. Many people get swelling in their ankles and legs, and it doesn't mean you have heart disease. Something as simple as varicose veins that many of us get, just from years of gravity can cause swelling in the legs. So that doesn't always mean you have a heart problem. It could, but not always. So this is a very complex disease, and there are a few different ways we treat this. The most common type of medicine we use is diuretic, also known as a water pill. Common name for this type of pill is Lasix or furosemide. There are several different types of diuretics we use to get extra fluid out of the body, out of the legs, and out of the lungs. We also use special types of blood pressure pills that not only lower the blood pressure, but help the heart relax and pump with more efficiency. There are many different classes of medications that we use for this. Too many to list for this talk. It could be a whole talk on its own. But the point is we use diuretic water pills to prevent fluid buildup, and then we use other types of heart medicines to relax the heart and help it pump more efficiently. The other thing that can help if you're dealing with congestive heart failure is being careful with your salt intake. Sodium. And the reason is wherever sodium goes, water follows. That's how our body works. So if you eat something very high in salt when you're dealing with congestive heart failure, you can develop fluid buildup very quickly. So a lot of the tasty foods that many of us love, we have to be very careful about. So one of the first things we do for people with congestive heart failure is counsel them on trying to keep a low sodium diet. And that can be hard. It can be hard to track how much sodium you're eating. We'll talk more about that in a minute. So now I just want to get into, we've talked about some of these points already, but ways to lead a heart-healthy lifestyle year in and year out and limit your chance of developing some of those problems we've talked about. And a lot of these concepts are very, very simple, things we already know. The real challenge and the tricky part is putting them into practice every day. A good diet, keeping active, doing some exercise. We all know that those are good for us, but it's hard to do day in, day out. There can be obstacles to each of those things. And then, of course, managing some of the common risk factors, like we've already talked about. So diet. I don't think there's any magic diet. Everyone's different. Everyone has different tastes, different backgrounds. So we all like different foods, but there are a few general concepts we can talk about for a good, heart-healthy diet. Avoiding processed sugars or limiting processed sugars. These are some of the things we all love. Cakes, ice creams, cookies, It's okay to have a treat sometimes, but it's the trends in how we eat that are very important. Whole grains are the best way to go when you're getting your grains. Whole wheat when it comes to pasta and breads. Brown rice as opposed to white rice. Portions are important as well. You really can't eat too many vegetables. There's no limit on how many vegetables you can take in. And, usually there's no limit on how much fruit you can take in unless you're dealing with diabetes, then you do have to keep an eye on your sugar. But fruits and vegetables are at the forefront of a healthy diet. We need protein. All of us need protein for energy, so there are many different ways to get it. If you eat meat, there are many different lean meats. For the most part, if you like meat, I would say lean toward chicken, fish. Red meat is okay sometimes, but again, it's the trends. It's how often you're eating these things. Seeds, nuts, beans are excellent forms of protein. Tofu, soy-based products. There are many different ways to get your protein in. Oils, there have been many studies on olive oil over the last few years, which show that probably is one of the best oils to use when you're cooking, if you're going to be cooking with oil. But again, I would just emphasize the portions and the amount you're taking in. And that leads into, some of the things we already know, but it's worth repeating. Just be careful with things like fried food, which are covered in oil. Just be careful with how often you're eating things like that and the portions. Again, my feeling, this is just my opinion, but I don't think there's one magic diet for people. There are many different ways to get a healthy, balanced, nutritious diet, and that has to do with blending different types of food and watching your portions. Now, this is my favorite topic, and if you take away one thing from our talk today, I'd like it to be the benefits of moving and exercise. I can't say enough about this. And I'm not asking anyone here to start training for the Boston Marathon or go to the gym and lift 200-pound weights. You don't have to exercise to that kind of extreme amount, but any bit of movement on a frequent basis, most days out of the week, is going to help keep you as healthy and as young as possible. There are many, many different ways to do this. Water aerobics, strength training, stretching, yoga, balance exercises, exercise machines, treadmills, exercise bikes. Now, of course, some people, when you're dealing with joint issues, hips and knees, it makes it difficult to get on a machine or go out for a long walk or a jog. You know, I understand that, but the point is, even a little bit of exercise, something that gets your heart rate up, gets you sweating a bit, is very good for you. I would say a good goal for exercise, some kind of activity, would be 3 or 4 days a week. If you do that, it's one of the best natural medicines you can give your body, even for a few minutes. Ideally, 25 or 30 minutes at least, 3 or 4 days a week, doing some kind of activity will keep you young and healthy. It helps improve your blood pressure. It's a natural way to lower your cholesterol. It helps control your blood sugar. It helps improve your sleep. It helps with weight, if that's a goal for you. It even helps with mood a little bit. So that's one of my favorite topics that I talk about every day with just about all my patients. And I know, some people rely on a cane or a walker or even a wheelchair to get around. So I'm not expecting that everyone's going to put on some running sneakers and go run outside. But just doing anything, even if it's just stretching exercises, something to get your body moving is so good for you. And then other risk factors for heart disease. We've really, with all of your great questions, we've just about covered all of these things already. But again, I would emphasize when I'm thinking about how I can help someone reduce their risk of heart disease, there are a few main things I'm always thinking about, and it's controlling blood pressure. That's one of the biggest risk factors for coronary artery disease, these abnormal heart rhythms that we talked about, heart failure. So that's important. And again, a good diet, without too much sodium, exercise is a natural way to control your blood pressure. And oftentimes we do use medicines. Many people are on medicine for blood pressure, and that's okay. If we have to use medicine, that's okay. High cholesterol, of course, that's something we can treat very effectively. As we talked about earlier, we don't know how to melt away cholesterol plaque yet. We haven't invented a way to do that, but we're good at preventing more plaque buildup, keeping the cholesterol from being high. Again, diet and exercise does that, and cholesterol-lowering meds. Statins are probably the most common type of med we use, but there are others too. Diabetes is a big risk factor for heart disease of all different kinds. So it's a very challenging condition to treat and manage. It takes a lot of work when you have diabetes to keep your blood sugar under control. But it's so important to keep trying and working on that. We work with patients and their primary care team and diabetes doctors, endocrinologists on this all the time. And of course, again, back to our point of diet and exercise helps with this immensely. And I didn't put a slide up here, but smoking. We already know all about that. So those are the main points I wanted to cover, and I have time for more questions.
I've never heard of the heart clinic. Is that something new?
Well, no. When I say heart clinic, I just mean the clinic where the cardiologists and heart doctors see patients. So we, heart doctors, we work in the hospital, of course. We see people who are in the hospital staying overnight with coronary artery disease, if they've had a heart attack or had these heart rhythm issues or heart failure. So we're always working in the hospital and doing procedures there too. But we're also working in the clinic all the time. So I'm in the clinic every day. My heart clinic is in just 15 minutes up the road in Sterling. I see patients every day there. I might be seeing people who've been having chest discomfort or trouble breathing and trying to figure out why that's going on and if there are any heart problems. I counsel people on how to prevent heart issues in the first place. And I also take care of people who've had heart attacks or strokes in the past or who've had these heart rhythm issues.
How big a factor does family history play in all of this? Because that you can't control.
It can be a huge factor. That's a great question. Most of the time, many of the conditions that lead to heart disease have to do with other illnesses that you have, whether it's diabetes, high blood pressure, high cholesterol, or if you've smoked. Those are usually the biggest contributors to serious heart disease. But family history and genetics is significantly linked to heart disease. And sometimes one of the most common conditions that someone can inherit is high cholesterol. So ironically, that's something I have. So I had very high cholesterol. I have a condition that I inherited from my family. Ironically, even the heart doctors, can have conditions to deal with. So that's a very common thing that some people have, an inherited high cholesterol condition. And some people are prone to having high blood pressure or diabetes. So that is something that we ask about when we meet patients. In fact, if you've had a family member, a first-degree relative, that's a sibling or a parent who's had a heart attack at a young age, that's a significant risk factor that we note.
We have noticed in our family, now my mother passed away more than 30 years ago, that the number for saying that you have high blood pressure or diabetes has become lower. It used to be higher. How is that determined?
Well, that's a wonderful question. So there's been a lot of research on controlling blood pressure and what the best numbers are. And the most recent studies on blood pressure, and they've been huge research studies involving thousands and thousands and thousands of people. The most recent research studies on blood pressure show that lower blood pressure seems to lead to a lower risk of cardiovascular problems, especially heart attack and stroke. So, based on those research studies that were so carefully done with so many different patients, our current guidelines for blood pressure are to aim for a top number, the systolic number, not much higher than the 110s, and a bottom number, the diastolic number, not much higher than the 70s. So that's, many of us are familiar with blood pressure numbers and will say, whoa, that's pretty low. My numbers aren't near there. The important, so the targets for blood pressure control, the guidelines have gotten lower over the years. Absolutely true. You're absolutely right. But the very important thing that the doctors and healthcare providers need to pay attention to is each individual patient. There are some of us who are not going to feel well if our blood pressure is 110, might get dizzy. So we have to be very careful to make sure we're not giving too much medicine just to reach a certain number. It's not all about just getting a certain number on the page. It's how you feel, how you're functioning. I have patients who feel the best when their top blood pressure numbers in the 120s, 130s, or 140s. And that's okay. As we get older, it's normal for our blood pressure to go up. As our arteries get older, they get a little stiffer. And our top number starts to go up as we get older, the systolic blood pressure. And the diastolic, the bottom number, tends to get lower as we get older. That just has to do with how our bodies age. So I might treat someone who's 80 years old, I might treat their blood pressure a lot differently than someone who's 20 years old. So someone who's 20, yeah, it would be great if their top number is around 110 to 120 most of the time. Someone who's 70 or 80 or 90, I might feel good and they might feel best if their blood pressure is on average a little higher. So everyone's a little different, and age is a big factor when it comes to treating blood pressure.
Can you explain tachycardia and how you treat it?
Yes, so tachycardia is the medical term for a fast heartbeat. And there are many, many types of tachycardia. Sometimes having a fast heartbeat, having tachycardia, is perfectly normal. Like when you're exercising, your heart rate is supposed to go up. Also, when you're exercising, your blood pressure is supposed to go up. So, don't be alarmed if your blood pressure and your heart rate jump up when you're exercising, because many of us track those things now. It's easy to track with all our wearable devices and equipment we can have. So tachycardia is a fast heartbeat. Some abnormal types of tachycardia, the ones we talked about earlier, atrial fibrillation, atrial flutter, two of the most common types of abnormal tachycardia. Where when someone has an abnormal type of tachycardia, we try to slow it down.
Do you have medication for that?
Yes, we have many different types of medication to treat abnormal types of tachycardia and abnormal types of heart rhythms. Many, many different types. And again, the type we use just depends on the individual patient and what's going on with them and how they're feeling.
Thank you.
Yep. So this is a great question, great timing too. Yes, so the bottom line is it's good to keep active. Now, some of us have heard those, terrible stories about someone having a heart attack while shoveling snow, and it does happen. And I think those sad, scary cases usually happen to people who have not been exercising, and all of a sudden, they go out with their shovel or their snowblower, and they're picking up that heavy wet stuff and stressing their body in ways they haven't been doing for a long time. So that's why it's good to maintain an active lifestyle all the time. If you're doing some kind of exercise or physical activity all the time, you're more likely to shovel snow and not have any issues. I think most of the time we run into those issues when someone has something bad happen when they're shoveling is, they probably were less likely to be exercising in the first place. And of course, they might have other issues, smoking or diabetes, high blood pressure going on too. So yeah, shoveling snow is not necessarily bad on its own. And we New Englanders have no other choice, especially this weekend coming up.
Okay, can I ask you a question about the blood pressure?
Yes.
If your systolic is 110 and diastolic is 55, is it normal?
It depends. It really mostly depends on your age. So yeah, that top number is fine. 110 is considered normal. That's in normal range. A bottom number of 50 or 60 or that's on the low side. That is pretty common and pretty normal if you're maybe 70 or 80 or older. So that bottom number tends to go down as we get older.
Okay, thank you.
Yeah. Okay, this is a very important question. So how about someone who's had some of these problems we've talked about? If they've had a heart attack or a heart rhythm problem, heart failure, what do they do? So specifically for someone who has coronary artery disease who's had a heart attack, first things first, we treat that problem, we treat the emergency, we help them stabilize. But after only a few weeks or so of getting through that event, we start talking about getting back on your feet and exercising. For people who've had heart attacks and stents and blockages and bypass surgery, because it turns out, even if you've had those terrible things happen, if you exercise, there's much more benefit to your health than risk. The risk of exercise in terms of exercise causing damage to your heart is actually very small. It's not zero, but there's much more benefit from exercise than risk, even especially actually if you've had a heart issue. And again, you don't have to be running marathons, but we strongly encourage some regular activity, aerobic activity, after a heart event. That's a great point to mention.
I would like to know if you are accepting any new patients.
Yeah. Yes. Yeah. So I would just like to, thank everybody. It's really an honor to be here and to talk about these things. I talk about these things every day with my patients. And yes, I'm here because I'm passionate about treating people who have heart problems and especially helping people prevent heart problems in the first place. That's the best way to go. Prevention is the best way to go. So that you'd never have to see us in the hospital. So anyway, I work in a clinic up the street 5 days a week. Yeah, and I'm always taking new patients. Yeah.
I go to Reliant Cardiology, and it's the best place you can go. They've been taking care of me. Dr. Kumar has been taking care of me for years. And I'll tell you, I've got the best care from St. Vincent's Hospital. So I just want to thank you. Thank you for coming, and thank you for being part of that team. You know, Joni Arakalian, you know them all. So I'm here, and I've had stents, and you know what? I can't say enough about St. Vincent's Hospital in the cardiology department.
Yeah, it's a privilege to help everybody. Thank you.
And you show it.
I'd like to know how much does alcohol contribute?
That's a good question. So the question is alcohol related to heart issues. So there is a relationship. And you may have heard different things about alcohol in heart health. So alcohol can cause heart disease. And it can cause, in some people, it can cause those heart rhythm issues we talked about earlier. It can cause atrial fibrillation if you drink too much alcohol. And it can cause heart failure if you drink too much alcohol. So you have to be, if you drink alcohol, you have to be very careful. And you may have heard, actually, the guidelines for what's a healthy amount of alcohol to drink keeps going down. Most recently, recommendations have been that, less than a drink or so a day on average is best. So yeah, it can cause a few different types of heart issues. It can cause heart rhythm problems, and it can cause heart failure. The other thing I would say, you may have heard about red wine and heart health, and there is this chemical that's been mentioned called resveratrol. So some people say, oh, drink red wine, it's good for your heart. It's got resveratrol in it. It helps with your heart and other things. That might be true, but there are downsides to drinking alcohol as well. So there might be some good chemicals in alcohol from red wine, I would say, from the skin of red grapes. But there's downsides to alcohol too. So one thing I would say is I never prescribe alcohol or tell someone they should drink alcohol for health benefits. If you like to have a glass of beer or wine, and sometimes a glass or two, that's okay. Just be careful with the amount you take in. But if you want to drink alcohol for the properties in red wine, or just eat some grapes.
Hi, you didn't mention caffeine. I was asking about the red wine too, but what about coffee?
So coffee's an interesting one. Coffee, there's been a lot of research on coffee, and this goes even beyond heart health. Coffee has antioxidants. It has good chemicals in it, and there is some research showing it might help with lowering your risk for certain diseases, and it might help with brain function. It's not really conclusive, But the same thing goes kind of as we talked about alcohol. Some coffee is fine. You know, if you like to have a cup or two every day, I think that's perfectly fine. It's unlikely that a cup or two of coffee is going to cause you heart disease. If you drink a lot of coffee, like if you drink close to a pot a day, that could raise your blood pressure. So that is not something I'd recommend. You know, many of us love coffee. I love my coffee every morning, but it's the amount. A moderate amount of coffee is fine. There's some. It's kind of a rumor that coffee will cause heart rhythm problems. It can make you feel jittery, and it can make your heart rate go up. But it hasn't actually been shown. Coffee hasn't been shown to cause these heart rhythm issues we talked about. So that part is kind of a rumor. So a little bit moderate amount of coffee is fine as far as your heart health goes.
Thank you, Dr. Mark. We learned a lot today in Heart Month. Elvis is going to set up. We're going to serve food soon. And thank you so much, St. V's.